private providers make up a large fraction of all healthcare delivery in many, many low and middle income countries, and their data is usually not effectively integrated into the overall system data, which means resource allocation, awareness of services that could be provided, knowledge of accurate quality assurance systems are all out of date frequently. So the 3 stages are critical in order to assure that improvements are effective to what should be a priority for each country in each context. Core data is already the priority in almost all low and middle income countries. It's often not yet there. Fixing that, making sure it's good, that's priority number 1. Core data consists of 4 things. First, consists of a master facility list that is regularly updated and an accurate reflection of the healthcare infrastructure that exists. The hospitals, the clinics, the laboratories, public and private, that should be the first thing, and make sure that's good. A registry of health professionals, their training, their accurate registration with professional bodies, that's the second. The third is vital statistics and civil registries, births and deaths, and up-to-date, accurate, timely reporting of reportable diseases. Plague, tuberculosis, yellow fever. When a provider in the private sector sees those diseases, there should be systems that are very efficient to ensure that that information is communicated to government. And the last is reporting on vertical programs, large-scale national priority healthcare programs like tuberculosis management, HIV/AIDS, and malaria. These systems usually exist, they're usually good, they very often include the private sector. Where that's not up to date, getting those in place, getting those working well is the priority. Level 2 is service delivery data. Expanding national HMIS systems, DHIS2 or others, to include private hospitals to begin with, private clinics, private laboratories by expansion, that's the next step. And incentivizing the timely reporting and use of those DHIS2 or other HMIS systems so that integrated data on service provision arrives within government analysts' offices and provides an integrated overall picture of care throughout the country. That requires digitization, training, support, and critically, feedback to private providers so that they have an incentive and they understand and value why this data needs to be accurate, how it's used, and how a working system is beneficial to them. Where those 2 levels are in place, the third level of data is financing data and health quality and outcomes data integration. That's possible in countries where a national health insurance or a national financing scheme exists, covers a large percentage of the population, and reimburses a large percentage of the private providers, hospitals, clinics, and the rest that are out there. Where that begins to be the norm, collection of data in exchange for reimbursement of services is possible, can be managed well, can be accurate and timely, and that builds on the level 1 core data and the level 2 service delivery data, and together provides an overall and very important view of the system, the healthcare that's provided, the costs, the needs, the vacuums, and allows for effective overall health system management. So not trying to get financial data or get an HMIS system to completely cover private providers if there are already gaps in core data is really the priority to understand the reason why this is a useful framework. It's critical for governments, it's critical for partners, agencies, individuals, and donors who are helping governments in low middle income countries. This needs to be done. Private sector data is huge, the private sector is huge, and good governance requires collection, integration, and use of that data, and that will benefit everybody. Thank you.